Assalamu alaikum. I'm Dr. Irfan Ahmad. I'm working as a consultant orthopedic surgeon in New Hospital, Lahore. As you know, under the banner, under the name of Surviving Orthopedic, I am conducting 2020 MCQ series for FCPS, MS, and DNB exam. So right now, we are going to conduct the sixth MCQ test of Surviving Orthopedics 2020 series. That will cover the sports section in one part. Total, there are two tests of sports section. So the question paper I already sent to all the colleagues in my group, and then we make a video of the answers and the explanation. So now let's start the session. So here it is. So as you can see, yes, this is Surviving Orthopedics MCQ test 2020, test number 6, sports section part 1. Sports, as before starting the test, I must tell you that sports section, with as the time is evolving and sports is becoming more and more in practice, and it's a hot topic nowadays in subcontinent as well, India and Pakistan. So the examiners are including more sections of sports. So remember that sports section, if there were questions approximately 10 in the exam, now they will keep on increasing to 15 or 20. So, and the other thing I want to tell you, if you haven't subscribed the channel, subscribe it, because what my channel contains, it's information for residents, how to get training, and regarding the preparation of FCPS, MS, DNB, clinical exam, theory exam, and above all, I have also started uploading videos of my surgeries and the feedback of the patients. So let's start with the sixth MCQ test. The first question was complication with an inside out technique compared to all inside technique for a medial meniscal tear. So this question has been tested in two different ways. At one stage they asked about the complication for medial meniscal, and the other they asked about the lateral meniscus. So the correct answer is saphenous nerve injury. And the explanation also contains that if we are going to repair lateral meniscus, what nerve injury can occur, and if we are going to repair the medial meniscus, what nerve injury can occur. Then, which of the following is not a contraindication to isolated medial meniscal transplantation? It is important to know the indication of meniscal repair, the contraindication of meniscal repair, and regarding indications of meniscal transplantation and contraindications of meniscal transplantation. And that's why this was an interesting question, because the candidate may confuse it with meniscal repair or meniscal transplantation. The answer was to this question is patient age over 30. This is not a contraindication. So these are the meniscal transplantation indications and contraindication. You must remember, especially the contraindication. You can't do it in inflammatory arthritis, instability of the knee, mark, obesity. This is also a contraindication. Remember this. The other question is best candidate for meniscal repair. So as I told you regarding meniscus, the size, the if they ask you question about the basic sciences of the meniscus, they will ask you what type of collagen is there, what type of percentage of water is there. So questions like this. And then they ask mechanism of injury, and they ask you signs, symptoms, clicking, locking, and all that. And then they can ask you about the tear and transplantation, and what are the candidates of repair, and what are the candidates for transplantation. So the correct answer is 4. And these are the indications of meniscal repair. Mostly in CPSP exam, as we have seen, they ask, when they ask about meniscal repair, the correct option mostly includes peripheral tear in the red zone. So zones are very important for meniscus. Which meniscal repair technique is considered gold standard? This is also a repeated question of CPSP, MS, DNB, even AAOS question. So inside out vertical mattress. And inside out technique, it is still considered gold standard. I have given you some of the explanation you must go through, because what are the planes where they go and what are the different structures they encounter. So you must be knowing this. Double PCL sign, it's a simple question and very commonly asked question even in Viva or theory exam. So bucket handle meniscal tear. Apart from this double bundle PCL sign, PCL sagging, and all that special signs, there's a beautiful picture in Miller as well of X-rays and MRI with description of different signs the examiners like to ask. So I think the explanation was not of this question; it was someone else. 8-year-old boy was playing at school and direct blow to his knee caused pain and swelling. He has discoid meniscus. Now, the patient examiner has given you the diagnosis as well that he has discoid meniscus and now he has developed mechanical symptoms. So, what is the treatment? The age is 8 years. So, the correct answer, the clue to the correct answer is in the last two lines that he has developed mechanical symptoms. So, if the mechanical symptoms have developed, then observation is not the right answer. Partial meniscectomy and saucerization. So when will you do non-operative treatment? Asymptomatic discoid meniscus and asymptomatic discoid meniscal tear. But it is symptomatic. How it is symptomatic? As he has told you that there are mechanical symptoms. This is an interesting question. Regarding this question is checking that the tests of instability of knee, and among these tests, the test specifically for anterior cruciate ligament, which test solely checks the rotatory instability. Basically, this question gives you a clue. Patient undergone reconstruction of ACL. His femoral tunnel is at 12 o'clock, and as you know that the two vertical tunnel basically does not provide rotatory stability. So, which test will be positive? Because this is a rotatory unstable knee after ACL. So, the test positive will be pivot shift test. Bone bruising. This is also a good, important question. In ACL, where the bone bruises are, when examiner asks you even in clinical exam that after ACL, what will be the signs, what will be the findings on MRI? So these also include, one of these is posterolateral tibia and lateral femoral condyle bone bruises. Which of the following should typically be avoided during initial therapy following ACL reconstruction? Well, physiotherapy of ACL, PCL both are important. The basic purpose, you must know when to do quads exercise, when to do hamstring, when to avoid them, and in all these exercises, this is a bit tricky question. Examiner would have added closed chain, open chain, but he is checking the knowledge of you as well, that whether you know what are the closed chain exercises and what are the open chain exercises. Among these, the seated leg extension. These are basically open chain exercises. When you are sitting and you are going to extend your knee, the knee is not closed chain exercise. The knee won't be in closed chain exercise. It is open chain exercise. So the correct answer is seated leg extension. You have to avoid among these. The next question is, what is the most common reason for failure of primary ACL reconstruction? So this question and is a famous question. I mean, this is a common question. So the answer is improper bone tunnel position. Complaint of numbness on the anterolateral aspect. This is a common complaint of the patient as we do the patients and we see later on. That's why there are new thoughts and new debate about the incision in ACL reconstruction. So the correct answer is infrapatellar branch of the saphenous nerve. Hamstring graft is associated with which of the following findings when compared to PTB? So PTB basically has increased incidence of anterior knee pain, and hamstring doesn't have this because in BTB, bone tendon patella graft, you take the graft from the inferior pole of the patella and the from the patellar tendon. Football player sustains contact knee while landing and develops immediate swelling, is noted to have a hemarthrosis, most likely diagnosed. Well, I believe that this question can have, even if this question can have meniscal tear or ACL tear, but there is always something in the question that is basically telling you. So, what is telling in this question? More appropriate answer. Basically, there can be more than one answer, but the most appropriate is the ACL. Why? Because immediate hemarthrosis is more common with ACL when compared to meniscal injury. Remember this. So during anterior cruciate ligament reconstruction and graft that is tight in flexion but lacks in extension may be due to which technical error? So there is a picture in Miller's orthopedic in ACL chapter. I must tell you the picture, and this picture basically telling that what can be the issues with two anterior two. So the correct answer is femoral tunnel is too anterior. So remember, you have to memorize when if after ACL it is too tight in extension and lax in flexion. So you have to memorize this and make a concept in your mind. Which of the following physical exam maneuver would be most expected for a patient with a Seagon sign on radiogram? This is also a tricky and related question. See, if there is Seagon sign, then what is the possibility that there is ACL ACL ligament rupture? Which of the following statement is true regarding BTB in comparison to quadruple hamstring graft? So this is also a common question, and the correct answer is that BTB has high incidence of anterior knee pain. Previously, people thought that it is biomechanically stronger, but it is not biomechanically stronger. The only benefit is that this is bone-to-bone union, and it occurs earlier than the hamstring graft. Which of the following mechanism is most likely to have caused PCL injury? Well, there is a picture in Miller's orthopedic, a table that tells mechanism of injury of every ligament. That is a beautiful table, and the correct answer is fall on the flex knee with foot in plantar flexion. So, likewise, PCL injury, there are different mechanism of injury. It is the best written in Miller's orthopedic sports section. Which PCL bundle is tight in flexion? So CPSP have also tested it often, that which bundle is tight of ACL, of PCL in flexion, in extension. So remember this. Anterolateral. All of the following they are true regarding grade 3 MCL tear of the knee. So in grade 3 MCL tear, well, MCL has few things that can be tested. Which MCL segment avalion has a high rate of union? If the MCL has avalion or mid substance tear, what will be the treatment option? So basically, this question tests your whole topic of MCL. So all of the following they are true regarding grade 3 MCL tear, except they require operative treatment when there is concomitant anterior cruciate ligament tear. So proximal ruptures have decreased residual laxity following non-operative than the distal ruptures. They result in 10 mm. They can result in Stener-type lesions. And proximal ruptures have better healing potential with non-operative treatment than the distal ruptures. So remember these things. 65-year-old healthy male has just undergone primary total knee. This is a question from arthroplasty, and it was written in this as well. We have discussed in previous test, and the correct answer is increased incidence of transfusion. During examination, noted to have positive reverse pivot shift test and negative posterior draw. In exam, they like to test the questions that involve PCL and PLC complex, and how you differentiate the both injuries and how you correlate both injuries in clinical exam. So it is important. They like to test the dial test, and often they, in previous attempts, even in consecutive 3 attempts, I have seen the question about dial test. So the correct answer is option 4. So here we have only PLC injury, not the PCL injury. So this is the explanation. 27-year-old football player sustains an acute lateral patellar dislocation. Which of the following is or are the most likely site of injury? Previously, this question was tested, and they were testing the bony value of the patella. But I have a bit changed the question to tell you that there are two types of more common injuries, and the correct answer is 2 and 4: soft tissue avulsion of MPFL and bony avulsion of patella. So lateral patella, patellar-femoral angle is the angle from patellar Recurrent patellar dislocation is an important topic, and the investigation X-ray CT, they are very important to memorize. The correct answer in this is option A, and this is a picture. This is taken from Orthopedic. This is a beautiful picture. Congruence angle, lateral patellofemoral angle, and lateral displacement. It gives you some information, so you have to remember this. And although quantitative uh, angles about these angles have not been tested, but they may test, so you must be knowing. After traumatic patellar dislocation, the MRI shows hemarthrosis and OCD. So patellar dislocation, if there is patellar dislocation, that what type of OCD we will most likely have? Although the patella dislocates laterally, but the correct answer is medial patellar facet. Predisposing factor for lateral patellar dislocation in native knee. So there are different factors. There are general factors, there are bony factors, there are muscle factors. In previous exam, bony factors have been tested and muscle factors also have been. I gave the question regarding general factor. The correct answer is 2, and these are the general factors. I have not mentioned here muscle factor or bony factor, but you must go through the bony factors and the muscle factor as well, because previously muscle and bony factors have been tested. Regarding this question, this is also a question from previous CPSP exam. Well, regarding anterior knee pain in adolescent, you must be able to differentiate on different bases. This is the question, and the correct answer is chondromalacia patella. We candidates often do not give so much importance to few topics, among which chondromalacia patella is also included. Try to solve questions regarding chondromalacia patella, and you will get to know what kind of question can come through this. uh, I have also uploaded a video of sports section quick review part 2, in which anterior knee pain differential has been described separately and with different question examples. What area of the knee is most likely to be affected by juvenile OCD? So this is a good question, because the locations and mechanisms, these are very important sports section. The correct answer is A. So you must be knowing that lateral aspect, but of medial femoral condyle. This is a question, and although the statement is too large, but this question was also tested previously, and the correct answer is activity modification. 10 years, and the OCDs in 10 years regarding treatment. Do not jump to operative treatment without any conservative treatment. Myositis ossificans, most common elbow, is a good question. And young male with knee dislocation that was reduced in year now presented. There is a beautiful flowchart in Miller Orthopedic treatment of MCL and ACL. You must be remembered. This question is a bit tricky question. In the past paper of CPSP, the correct answer is MCL repair and ACL reconstruction. Although the correct option uh, in this case is MCL repair and ACL reconstruction. He has Lachman positive, his valgus stress test is 10 positive. This is grade 3. This is grade 3. So in Miller's flowchart, they've given you the treatment of grade 3 MCL and ACL. Do watch that. Apart from this sports test, we will be conducting the next sports test next week, and you can watch video of sports section quick review. There are 2 videos, and these are good to have a quick review of sports section as well. I hope this video will serve the purpose. You can ask me questions, and you can give your suggestions as well regarding the difficulties you are facing in theory preparation. So thank you so much. I hope that this video will serve the purpose.